Okay, it looks like the number of people logging on is fairly stable here, so we'll get going. Thank you all so much for joining Dr. Bradley and myself tonight for this discussion and educational session on pelvic organ prolapse. We greatly appreciate you taking time out of your busy schedules, and we hope that really you will find some information within this next 45 minutes or so that can help you better understand what pelvic organ prolapse is and potentially make more informed decisions into the future. Just a few housekeeping steps here first. One is me getting my screen to work. For question and answers, many of you submitted some questions prior at the time of registration, and we will try to make sure that we answer those throughout the evening. However, if as we're speaking, you think of other questions, feel free to put them in the little question and answer box at the bottom of your screen. And secondly, there is the ability to do closed caption or show the subtitles from what we're saying this evening. So I'll give you a minute to turn that on if that is what any of you need. So as I said, thank you very much for joining us this evening. My name is Dr. Elizabeth Takis. I'm one of the urologists here at the University of Iowa who specializes in urogynecology or female pelvic medicine and reconstructive surgery. And I'm joined tonight by Dr. Catherine Bradley from the Department of Gynecology, and her specialty is urogynecology. So both of us treat disorders of the pelvic floor, including pelvic organ prolapse. Along with us, there are three other providers here. Our colleagues are Dr. Kimberly Kinney, Dr. Joseph Kowalski, and Dr. Anna Volstead. So we have a 5-member team of physicians who treat pelvic organ prolapse. We have visits at a number of locations. Here within the Iowa City area, the predominant sites are either the University of Iowa Hospitals and Clinic main campus or the Iowa River Landing building. For those of you who may not be immediately within the Iowa City area, there are some outreach sites where either one or several of the physicians may attend. The Dr. Kowalski, Kinney, or Bradley also have outreach clinics in Cedar Rapids and Davenport area, and Dr. Volstead sees patients in Grinnell. Just to start off, I always think it's important to know what we're talking about. And so we like to always start about, talking about what's normal anatomy. And so in a woman, Kate, can you see my little cursor at all? Okay, so, here's the pubic bone, and this is what you're gonna feel if you push on the front wall of your tummy. That hard bony structure at the bottom. Then you have the urethra and the bladder, the vagina, and the uterus kind of sits at the top of the vagina and puts a little bit of pressure on the bladder. In many women who've had a hysterectomy, the uterus will be absent. And then the back wall of the vagina represents, where the rectal area is. So if we were to make a cut through the back wall of the vagina, eventually we would come down to the rectal area. What pelvic organ prolapse is, it's the descent of one or more organs through the vagina. So as this schematic shows, either the bladder, the top of the vagina or the uterus, or the back wall can bulge into the vagina and even outside of the vaginal opening. Pelvic organ prolapse can be of just the bladder, the uterus, or the rectum, or it can be a combination of organs. And it's really important for us to have an understanding of what is descending so that we can have a better idea of treatment options for you. This is an example of what happens when the bladder falls. You see here is the back wall of the bladder, and it's kind of bulging in onto the vagina. Here is an example of what we call a rectocele, where the rectum is bulging through the vaginal wall. And this is an example of uterine prolapse. Again, if you don't have a uterus, or if patients don't have their uterus, they still can have prolapse of the top of the vagina. We just refer to that as apical prolapse then. And this is an example of that. When we are thinking about prolapse as physicians, we often like to think about what stage or what is the degree of droppage or descent of the various organs. So we talk sometimes about stages. Stage 0 is really where everything is in good support. I always focus on 0, 2, and 3. Stage 2 is where things are kind of around the opening of the vagina, maybe a little bit on the inside, but maybe a little bit on the outside, and people are starting to feel vaginal bulges. And stage 4 is really when the vagina has totally everted, and either the uterus or the top of the vagina is well beyond the opening of the vagina. In general, patients have about 19% of needing to have surgery to correct pelvic organ prolapse throughout their lifetime. So for patients that are suffering from prolapse, they are not alone. This is a common condition in women. What are some of the risk factors? So pregnancies, having multiple deliveries can be a risk factor for the development of prolapse, as well as aging, obesity, constipation. We do see that sometimes family history can be predictive of prolapse, or prolapse can run through moms and sisters and aunts and grandmothers. Also, though, a hysterectomy can potentially give a slight increased risk of prolapse over time, but it's a little bit harder to define that. What can you do to prevent pelvic organ prolapse? Well, we don't know. It's not really well studied. There are so many variables that are involved, but these are some of the things that may prevent the risk or the development of prolapse over time. C-section delivery may reduce the risk, but it's not 100% preventative. So if you are a young woman who's still in childbearing age and planning on further deliveries, it's important to have a discussion with your obstetrician or your person managing your pregnancies to discuss the risks and benefits of a vaginal delivery versus C-section for you. Kegel exercises or strengthening of the vaginal muscles may potentially prevent some degree of prolapse. Weight loss, decreasing constipation, and avoiding repetitive heavy lifting. There are some common symptoms of, many women may not have symptoms of prolapse. Maybe the bulge or the dropping organs are still well within the confines of the vagina, so they may not really notice that things are starting to descend. But one of the most common complaints is either seeing or feeling a bulge at the opening of the vagina. It's almost like there's extra tissue coming through the vaginal opening, but this is really one of the most common complaints or common symptoms of pelvic organ prolapse. Other patients may have some element of pelvic pressure, but not all pelvic pressure means you have prolapse. Vaginal irritation from either the bulge or the prolapse tissue rubbing on clothing or undergarments or things for incontinence can develop. Some patients may have difficulties urinating or having bowel movements unless that they push or manually reduce the prolapse back into the vagina. And some patients may have some difficulties with sex or sexual intercourse. It is really important to know that for some of these bottom 4 symptoms, the pelvic pressure, the difficulty with sexual intercourse, bladder, bowel dysfunction, having those symptoms does not mean that you have pelvic organ prolapse, but they are important to think about as a potential cause, or prolapse is a potential cause of those. Urinary leakage is a common complaint. So the leakage can be either coughing with activity or lifting, what we call stress incontinence, or it can be urgency frequency, but it is not necessarily caused by prolapse in all cases. And I think one of the most important things is severity of the symptoms, especially the symptoms of pressure, urinary or bowel issues, does not always correlate to the stage or the severity of prolapse. So when you see someone to discuss your pelvic organ prolapse concerns, it's important to have the conversation with the provider. They may have you do some questionnaires, discuss the different symptoms as far as bladder symptoms, bowel symptoms, sexual dysfunction symptoms, and what is actually the impact on your life. What type of prior treatments or evaluations have you had, prior GYN history or obstetric history, and then just a general past medical surgical history so they can assess your overall condition and risks for surgery. Other evaluation is going to include a general examination, including, examining your abdomen, as well as a pelvic exam. The pelvic exam is really critical for us to determine potentially what is dropping, the extent to which it is dropping, and that really will help us shape and formulate what treatment options are best for you. In some patients, we may require additional urinary tests or even bowel testing to see how much their symptoms are related to their degree of prolapse. So how is prolapse treated? At this time, I'm going to transfer it over to Dr. Bradley.
Okay, thank you. We could go to the next slide.
Oh, sorry.
I was trying to do it. All right, so there are several treatment types available, and I tell many patients that, first of all, we don't always have to treat prolapse. Sometimes we do an evaluation and we can figure out what type of prolapse a patient has, and if they're not very bothered by their symptoms and perhaps it's mild, it's not causing a lot of problems, we're reassured that we know what's going on. We don't have to do anything, and we can kind of do watchful waiting. Sometimes those patients might decide to come back in 6 or 12 months, and we might reevaluate them or check in to see if any symptoms are changed, or they may choose to just come back as needed if things worsen, and those are both fine approaches. Another treatment we might offer is a vaginal or topical estrogen treatment. So this is using a vaginal cream or tablets or a ring that secretes vagina estrogen into the vaginal walls. This is a treatment that really helps with the symptoms of the bulge and may make it less irritating or uncomfortable. Sometimes a vaginal bulge can kind of rub on the sides of the vagina as people move or are doing certain activities. We're not really sure that estrogen changes the presence of prolapse necessarily. Rather, I would say it kind of treats the symptoms, and sometimes it can help some of the associated things like people who might get a urinary tract infection. It can decrease that risk, or it can decrease, might help some frequency urgency symptoms. The next kind of treatment often offered for pelvic organ prolapse would be strengthening the pelvic floor muscles. And we often do this by referring patients to see a pelvic floor physical therapist. Other times, patients who are able to contract their muscles well on their own can do this at home. And we'll actually check on our exam when we're assessing a patient for prolapse and figuring out which organs are dropping and how much, as Dr. Kack has said. We may also check to see if patients are able to effectively contract their pelvic floor muscles, which we often call a Kegel exercise. And then we'll also talk tonight about pessaries or a vaginal device to treat prolapse and surgery. And so this slide just demonstrates a type of vaginal pessary. And this is a kind of soft silicone-based ring or disc. That's the most common kind of shape pessary, although we have a wide variety of shapes of pessaries. We have oval pessaries, we have little pessaries that look like a donut or a cube. One of our more common types for prolapse is called a Gellhorn. And they come in all different sizes from small to large. And so if people are interested in a pessary, this is a great way for patients to self-manage their symptoms and avoid the risks of surgery if they're not interested in surgery, or if they maybe can't have surgery because of medical problems that mean they might have increased risk for anesthesia, for instance. A pessary is placed in the vagina, and when you're wearing the pessary, it's lifting up the bulge or the organs that are dropping so that you don't feel the bulge that's there. And it kind of straightens out those vaginal walls. So if there are associated bowel or bladder symptoms, generally those are improved. And it typically involves coming for a visit specifically for pessary fitting, where we try different shapes or sizes to get the right pessary. When it's in the vagina, in the correct location, you shouldn't really be aware it's there. It's kind of like having a fitting for a contraceptive diaphragm, and wearing it should be a little bit like wearing a tampon, where you're not really aware that it's there most of the time. It should stay in the right place. It shouldn't be uncomfortable. It shouldn't fall out. And then most of our patients, we actually teach to manage the pessary themselves. 3 out of 4 of the patients in our clinic self-manage their pessary, meaning they're able to remove it themselves, typically once a week, put it back in, maybe after an overnight without the pessary, put it back in, and then just take it out that one time a week. Other people like to remove it more often. Most people remove a pessary for sexual activities. Some types of pessary you have to remove for sex because they really occupy the whole vagina. And these are, again, non-surgical ways of managing prolapse. They don't cure the prolapse. You have to keep wearing the pessary to treat the symptoms, but it's a low-risk way for patients to manage their prolapse. Okay, and then we're going to go through several surgical options. And I think what's important to understand about surgery there are a lot of options, and we will kind of talk to patients about many of these and usually tailor the best surgery to patients based on their preferences and other factors involved in their history or the type of prolapse they have. We have surgeries that are performed more from the abdominal side, either through an open incision or often now through small laparoscopic incisions or using robotic surgery, so we can do it in a minimally invasive fashion. The abdominal approach uses a graft, which is most often a synthetic mesh, and I'll mention that in the next slide coming up, to help kind of augment the repair and hold up the prolapsing organs. We do a lot of vaginal approach surgeries where all the incisions are inside the vagina, and typically those surgeries do not use any kind of additional grafts. They use the patient's own tissues and kind of ligaments and use sutures and things to try to do the repair. And both of those first types of surgeries I mentioned are kind of reconstructive surgeries where we are resuspending the vaginal walls and correcting the prolapse so that the vagina is kind of normalized in terms of its shape and location. You can have normal intercourse. But we also do vaginal closure surgeries where we are actually intentionally closing the vagina. And this is appropriate, of course, only in women who are never planning to be sexually active again. It's a little bit less invasive, but effective. And so it's often used in kind of our oldest patients or patients who are not sexually active and don't plan to be. And this slide is complicated and really is it's from one of our kind of a review paper that had this complicated algorithm about all the different types of surgeries that we have. And I think we wanted to show you just to kind of demonstrate that there are many different options, and we are able to really tailor our recommendations to individual patients because of that. It's not just a one procedure, for everybody, I would say. And as I was just mentioning, this is complicated because there are many different types of pelvic organ prolapse. So you could have prolapse that involves the front wall of the vagina under the bladder. that would be, we sometimes call that a cystocele or anterior bladder prolapse. And I think you can go to the next slide. I think it shows the a diagram there. And then you could have prolapse involving the posterior vaginal wall where the rectum might bulge forward. And we need to address that during surgery. And then sometimes, of course, the uterus or the apex of the vagina, if there's no uterus, is dropping or falling as part of the prolapse. And then that may be the most important part of our surgery. More and more, we realize that to have successful procedures, at least in most patients, we have to suspend the top of the vagina and correct that apical prolapse. So I'm just going to show you a few pictures from some of the most common types of surgeries that we do. This first one is called sacrocolpopexy. This is the abdominal approach to surgery. And so again, we're making incisions on the abdominal wall, either a larger incision or little laparoscopic incisions. And then we are elevating the vagina by placing a graft. And you can see here that this white line represents the graft that was placed, and it's kind of like a Y. It goes around the front and the back walls of the vagina and then extends up to kind of the tailbone in the back of the pelvis, and we sew it to a ligament that's there. And this sacrocolpopexy surgery is one that we do often in patients with more severe prolapse or patients who have a lot of risk factors for recurrence. Maybe people who have had previous surgeries that have failed and we're worried that their risk of recurrence prolapse is high. This surgery is a little bit more durable, a little higher success rate, but there are a few more risks because we're going into the abdominal wall and because we're using the graft. And that's most often, a synthetic mesh. And I think the next slide shows what that looks like. This is the actual little blue mesh there. It kind of looks like a netting. It's kind of like, it feels a little bit like a soft, like fish line that's been woven into kind of a fabric. It's soft and it's a little bit stretchy. And it's designed specifically just for vaginal prolapse surgery. And people often have some apprehension about mesh. They've seen ads or concerns for problems. And in 2019, the FDA actually withdrew its approval for certain types of mesh used for prolapse, but they were actually different from this surgery that we're talking about. They were called transvaginal mesh. There was not any kind of warning or withdrawal or ban of the procedure for mesh that we're talking about today, this abdominal approach. And the problem with the transvaginal mesh was that the risk of complications was much higher, in particular problems with postoperative pain and other problems with the mesh. And those, again, were much higher with those surgeries and are not as high with the abdominal sacrocolpopexy. So we feel this mesh is still a foreign material, and there are risks with any kind of implant, but it's much less common, and it's something that we talk about as a known risk with those surgeries. But we think the mesh is really what makes the surgery a little more durable. Okay, and then just talking about a couple different types of vaginal approach surgeries, and these are a little bit just some schematics that show two types that we frequently do. These are procedures to elevate the vagina when you're going with a vaginal approach. So again, we do all this through incisions inside the vagina, no incisions on the abdomen, and we use stitches to hold up the top of the vagina to different ligaments. So one of these types of procedure is called the uterosacral ligament suspension. I think Dr. Takis is just pointing with her arrow or cursor there. And the second one is called a sacrospinous ligament suspension. They're actually equally effective. We've got studies that show that both of them are probably 75 to 80% effective at curing bulges. and not too many people after them elect more treatment. And in this case, the surgeries are a little bit shorter and they have slightly less risk because we don't have to use that graft or mesh. However, the risk of recurring prolapse is a little higher with this than with the abdominal surgeries with men. And then finally, the other kind of category of surgery I mentioned was the vaginal closure surgery. This is, in medical terms, often we call this a focal plysis surgery. The benefit of this surgery is that we can sometimes leave the uterus in and perform this vaginal surgery just in a shorter amount of time. And it has very high success rates, very low complication rates, not a lot of postoperative pain. And so it's one that's really appropriate for kind of our most oldest patients, and those obviously only appropriate in those not planning to have vaginal sex in the future, because it significantly shortens the vagina. So there's the upper 2/3 about of the vagina are kind of closed, which is what allows, really helps with correction of the prolapse problem. And just before I talk about after surgery, I thought I should mention one thing that I didn't make clear before, and that is that if you still have a uterus and you have uterine prolapse, we often include hysterectomy with prolapse surgery when the uterus is involved, but we don't have to. There are some times where we do suspension procedures, either abdominally or vaginally, leaving the uterus in place. And that's something that could be appropriate in some cases, depending on the patient's anatomy and type of prolapse and other factors in their history. So I thought I would just mention that. So after surgery, the good news is now that many of our surgeries are done in a minimally invasive way or vaginally, that many of our patients go home the same day as their surgery, or might just spend one night in the hospital under kind of observation care and go home the next morning. Patients are immediately advanced to a regular diet as soon as they feel ready to eat normal food. And most of our patients are able to control their pain using over-the-counter Tylenol, Advil, or ibuprofen, and not so many, or not too many need stronger narcotic or opioid medications, or they may just need that for a couple of days or a shorter amount of time. And it's very variable, but it's depends on each patient, say. It's important that we use some type of stool softener or sometimes laxatives after surgery, because constipation is one thing that definitely can affect our patients right after surgery. We don't want patients to have sex or put anything in the vagina for a period of time after surgery, 6 to 8 weeks. And we typically ask people to reduce their activity a little bit, avoiding heavy lifting, maybe not more than 15 pounds, and avoiding kind of strenuous exercise for 6 weeks. But again, most of our procedures now, patients are up and doing things for themselves immediately. They are able to take care of themselves at home. They're able to walk up and down steps, just not doing heavier lifting or strenuous activity, but walking is okay. For instance, get out of the house and get some exercise. So it's not like people are on bed rest or really restricted in their activities for 6 weeks. And people immediately can shower. We typically don't recommend baths or swimming pools or saunas in the first 4 to 6 weeks. So the last thing is, what about my urinary leakage? So I will just say that in the patients we see with pelvic organ prolapse, about 50% also have significant urinary symptoms or urinary incontinence. And if they have stress incontinence, again, as Dr. Packus described earlier, that is the leaking with physical activity. that is something that we would often recommend treating at the same time as the prolapse surgery, often with a surgery called a sling surgery. If they don't have incontinence, well, at first I should say, if they have a patient has urgency urinary incontinence, um, often that will improve with their prolapse surgery. On average, women's symptoms of like frequency of urination, urgency, and sometimes leakage with urgency. Sometimes the symptoms related to difficulty emptying, like having a weak or intermittent stream or feeling like they're not emptying their bladder. Those symptoms overall tend to get better after prolapse surgery. They're not always cured, but they tend to get better. One thing we talk to women about is that some women who don't have stress incontinence before their surgery, there's a risk that they could develop new stress incontinence after prolapse surgery. And that's something we would talk to you about in the office for patients who are interested in surgery. And we would do some extra testing before surgery to try to figure out which patients are most at risk. And then sometimes we offer a surgery with the prolapse surgery to try to prevent that outcome. So I thought we would mention that's sometimes part of our workup, and especially if we're planning surgery. And I think that is getting close to one of our last slides. We want to make sure you understand that prolapse is definitely a relatively common thing. People don't talk about it a lot, but obviously, we see this every day. This is what we focus our practice on often, and treatment is possible. So both surgical and non-surgical treatments are possible. And if the prolapse is mild and you really don't have a lot of symptoms and aren't having any problems, then sometimes we can just observe and monitor. And it does not always worsen with time. Some studies suggest that in cases of milder prolapse, only about 10% of people will have significant worsening when they're followed for 2 to 3 years. It's probably a little bit higher in terms of prolapse worsening, more like 30% once people have more kind of moderate amounts of prolapse if we just follow them over time. So last, as Dr. Takas showed at the beginning of the presentation, we are specialists in urogynecology, whether we're from OBGYN gynecology background or urology background. We focus on pelvic floor problems in women. Most often pelvic prolapse and urinary incontinence are the most common diagnoses and conditions that we treat and evaluate. And we've been trained specifically to do this. So we feel like we have a lot of experience and expertise, and stay on top of the newest things out there and the best information to try to offer the highest quality care. Anybody who provides urogynecology care, it really should be what we say multidisciplinary. So, as I mentioned, we're urologists and gynecologists. We work closely with other providers like gastroenterologists or GI doctors and specialists, with colorectal surgeons who focus on sometimes rectal problems and bowel problems that we work with them on. We work with physical therapists who are really important in our practice. So these are specialized pelvic floor physical therapists who see and treat women who have urinary incontinence and prolapse and pelvic pain problems specific to the pelvic floor muscles. And they are really excellent. And we work with there's 4 women providers here in pelvic floor physical therapy, but we also work with pelvic floor providers across the state in physical therapy, because people can't always come here. If they come a long distance to see us, they can't keep doing that frequently necessarily for their physical therapy. And I do think we provide very patient-centered care where we're trying to guide treatments but based on patient preferences and goals. And as hopefully you could tell from the talk today, we have a lot of options, and we focused a little bit on surgery. I think a lot of people are interested in that and have questions, but of course, I also mentioned the non-surgical options like pessaries, like Kegel exercises and physical therapy. So there are other things available as well. And
And this I was just going to say, and this is just more the final slide. We'll cover the questions here in a moment, but it's just to let you know, if you are a woman or someone else you know is suffering from recurrent urinary tract infections, in September of 2023, it seems like a long ways away, but it'll be here before we know it. We're going to have a seminar to discuss, some of the risks and ways to prevent or manage recurring infections. So now we'll open it up for questions. I'm going to just start by asking Dr. Bradley a question or two, why I kind of rearrange my computer screen so I can see all of the questions. But what I would say, Dr. Bradley, is, many of the questions that were submitted were from patients that had concerns about having had prior repairs or a prior hysterectomy. Does that change your approach to these patients, or are there options for them?
Yeah, those were good questions. So first of all, there's a little bit of evidence that having hysterectomy may increase the risk of pelvic organ prolapse in the future, but it's not a big change. We know that we see a lot of women who get prolapse who've never had a hysterectomy, as well as people who get prolapse who have had hysterectomy. So there's a lot of other reasons for prolapse as well. And obviously when people come to see us and they've had a hysterectomy, we still are able to offer very similar types of treatments. In other words, non-surgical and surgical options. We had a question, at least one, about somebody who mentioned they had had a hysterectomy and some prolapse repairs. And unfortunately, it sounds like the prolapse came back within a few months or fairly rapidly. There's a risk after prolapse surgery that prolapse may recur. And once in a while, it can do so in, fairly short time period, although that's not too common. And we certainly see patients like that, and we can sometimes figure out that maybe a different surgical approach would be more successful, and can talk about that option. Or we sometimes see patients who've had that experience, either their prolapse came back right away, or maybe not. Maybe they had a good result for a period of time and then have had new prolapse come back. And we can still offer non-surgical treatment for those patients. So once you've had surgery, that doesn't mean you only have to have surgery in the future. We can still sometimes use physical therapy or pessaries as well.
We also had some questions on signs and symptoms, which I'm going to just answer those right now. One question was on having a rectal prolapse. And I want to emphasize that rectal prolapse is actually very different than a rectocele. Mm-hmm. A rectocele is where the rectum is bulging into the vagina, causing the vaginal tissues to descend. Whereas rectal prolapse is actually the rectum is falling through the opening of where you have a bowel movement. So they can be very different. Both you may be feeling a bulge, but if you feel like you're having more symptoms further back, more bulging further back, the evaluation would really involve potentially colorectal surgery for treatment options of that. And there are some patients who have pelvic organ prolapse and rectal prolapse at the same time. So it's very important to make sure that we have a good understanding and knowledge of all of the conditions so that we can potentially do a combined treatment and therapy when it is possible. Another question that came up is, what if you can't really feel that area for other medical reasons? You just don't have a lot of sensation in the vaginal area, what we call the perineal area, which is down around the vagina and the rectum. And you may not be having symptoms, you may not sense pelvic pressure, but I think what's really important is one of the biggest, most common symptoms, and one of the ones that really drives us in considering surgery, is that feeling of the bulge. and some of the discomfort of the bulge. So even if you can't feel pelvic pressure, it's okay. You may notice that you have prolapse when you start to feel a bulge or something coming out of the vagina. And then I mentioned, repetitive heavy lifting, repetitive, chronic constipation. What I would say is what a person does on an average day is probably not falling into that repetitive category. We do have some patients that have very manual jobs where they're lifting very heavy equipment, or maybe within a janitorial staff, or sometimes within healthcare where they're dependent on moving a lot of patients. So that's more of the chronic heavy occupations. Going to the gym, I would say what the average person does, maybe 15, 20 pounds kind of maximum, probably isn't going to cause the prolapse. But what we want to avoid is a lot of that really kind of strenuous, all effort trying to lift something above your head or push something up or lift something, because that is when the risks exist. Do you have any other thoughts on that, Dr. Bradley?
No, I think that's a good point. It's hard to counsel patients because we have studies that have linked prolapse to that kind of heavy repetitive lifting, but they're not very exact, I would say. So it's kind of hard to know for sure, like exactly what exercise is most risky or exactly how much weight can I lift. And we don't really have great research to guide us in those kind of very specific questions, I'd say. So I think just avoiding the most strenuous lifting and stuff, and when you can, avoiding things, that kind of heavy lifting on a very repetitive basis is usually what we recommend.
Okay. Another question is, how old would you say your typical patient is coming in with pelvic organ prolapse?
So the average age of people seeking surgery for prolapse is typically about 65. But having said that, I have to say we see patients in their 20s, not very often, but some. I've even done some surgeries on women in their 20s. And then we see patients in their 90s, and once in a while even do surgery on women in their 90s. So it is a really wide range, although there's, I'd say, a big group of people, present 50s, 60s, 70s, probably the most common.
I would agree with that. And I think one of the really important things is this is an individualized problem. It's an individualized treatment option. And you can be seen and evaluated, and it doesn't mean that you're signing up for surgery. I think it's always important for patients to find out what are my options, so then they can make a better informed decision. I often tell kind of the more elderly patients that I see that in my world, you're never too old on paper to have surgery. If you have a lot of medical conditions, we may have to have a good discussion on what's the risk of anesthesia for you, and is that a good option? So I think that's always something to think about, is the age of you on a piece of paper, that doesn't necessarily mean a lot. It's kind of how you are health-wise. I was just looking through here. I had another question. We just touched very briefly on some of the incontinence. And maybe what you could do is, a couple questions were geared, what are some of the treatment options for stress incontinence? I know tonight is not about urinary incontinence, but just for the treatment of stress incontinence, can you give us a little bit of overview on the general categories?
Sure. So it's actually not that different from prolapse, really. In terms of general categories of treatment for stress incontinence, it includes pelvic floor exercises and physical therapy. It would include different vaginal devices. There are some over-the-counter inserts. There are accessories that are actually specifically for stress incontinence rather than prolapse, or for women who have both. It can help. And then we have office procedures and surgeries. The most often surgery we do for stress incontinence is called a sling surgery, and that's putting a little strip of a graft on either some tissue from your own body or a mesh strip kind of behind the vaginal wall underneath the urethra. And so that surgery we do a lot for women with stress incontinence. And as I mentioned earlier, sometimes we include that with our prolapse surgeries in women who have stress incontinence and prolapse.
Great, thank you. And one more question that had been raised beforehand, and I actually really love this question because I think there's a lot of women who are afraid of this happening, is what happens if suddenly I feel an enormous bulge? What happens if my uterus or my bladder suddenly falls out and it's really bothersome and it's really uncomfortable? And I think that's a question. I'm glad someone asked it because not a lot of people want to ask that question, but I think it's on everybody's mind. And what happens is if you feel a bulge, you can push it back in. It may come back, but you can certainly try pushing it back in. You don't have to go running to the ER. You don't necessarily need to be seen by your primary care or a gynecologist or a urogynecologist immediately. Except what I would say is unless it's really painful, uncomfortable, you can't urinate, you can't have bowel movements, then it's more of an urgent matter. But if you're finding that you suddenly have a bulge, don't be alarmed. You can push it back in. You can look at it with a mirror. It's very hard to hurt the bulge at the end of the day. And so you don't have to be overly gentle. It's not like something that's going to break if you touch it. So you can be confident in pushing it back in. For some women, it can be a little bit uncomfortable, though, trying to do that. For some women, they'll push it back in, and as soon as they stand up, it's back out. But if you are suffering from prolapse, you also might notice that when you lay down at night, it goes away. When you first wake up in the morning, it's not there, but it comes on throughout the day. And that's just because gravity isn't necessarily our friend, and kind of standing on your feet or the coughing or the straining is what brings it back down.
Mm-hmm. And I might add, that's a great point. I might add to that, that it's the great majority of people, it's not a sudden and acute worsening of prolapse, or usually it's kind of a more gradual thing. And it might be that you just didn't know it's there, and that's kind of scary that suddenly there's this new bulge there that you didn't know was there. But usually it's coming on slowly and being more gradual. And I think I mentioned that we don't always think it's going to worsen. You know, it won't necessarily keep getting worse over time. So sometimes people will come to see me because they noticed it, and they've noticed it, it's been there for 6 months, or they've noticed it and then it seems to be getting worse for 18 months. And we don't necessarily know that it's going to get worse over the next 18 months. It could, but not in everybody. We definitely see people where it seems to kind of stay the same, and it might be the same for many years, and then it might worsen again in the future.
I don't know, Dr. Bradley, do you have any other closing thoughts? I think we've covered most of the questions. If anybody has a last minute question, feel free to put it in the Q&A box, but any last minute thoughts, Dr. Bradley?
Let's see, we talked about some, there were questions that we covered about kind of options, non-invasive options like pessaries and physical therapy. Somebody asked about pessary and causing cancer, and there's no evidence that I'm aware of that kind of link in any way. Pessaries are nice because they don't have a lot of risks. There's a small chance that they could cause some irritation on the vaginal walls, typically in older patients with thinner tissues, less estrogen around, and we can sometimes help that with some topical estrogen. But yeah, I think that we pretty much covered everything. It was great questions to respond to. Oh, you're muted.
I have a couple more questions coming in here, so this is great. I think it's something we didn't talk about. What are the risks to sexual function after surgery? We totally didn't talk about that.
We missed that. So that's a great question. First of all, again, we usually ask people not to have vaginal sex for about 6 weeks after their surgery, give or take some, depending on your procedure. After that, we usually encourage people to be sexually active again after our reconstructive surgeries. And most of our evidence suggests that sexual function is actually going to improve after surgery for prolapse. So usually when people's bulges are treated and after their surgery, they actually have better function. There are some small risks of problems like pain with sex that can happen after surgery, or sometimes narrowing or scarring in the vagina can occur from surgeries. These are not very common, but there's something that they're great questions to ask your surgeon, and we usually do talk to patients about those small risks. But as a whole, most people's function gets better or is the same after surgery.
Okay, great. Another question was, can the uterus come all the way out? Yes, it can. It can bring the entire top of the vagina down. And as it comes down, it's going to pull the front and the back walls with it. Again, kind of think of taking a sock and pulling it inside out. And that's kind of, as you grab the toe, you're pulling the uterus down. The cervix will typically be the furthest part. It's not like the top of the uterus is going to pull through the vaginal wall. So if you feel it, you might see kind of the shiny or pink of the cervix, or the little dimple on the cervix. And it can come all the way out, but the uterus itself will be within the confines of the front and the back wall, just inside out. And then urinary incontinence and pelvic organ prolapse are different. They're two different conditions. They can exist together in the same patient. But if you have incontinence, it does not mean that you have pelvic organ prolapse. And if you have pelvic organ prolapse, it does not mean that you're going to have urinary incontinence. So they're really two different conditions, both conditions of the pelvic floor. They can occur simultaneously, or they can occur in isolation. So I think that's all the questions that we've had and we've received. It's been a great evening. I hope that we have answered a lot of your questions, or we've improved your knowledge on what pelvic organ prolapse is. And I think if you have questions or anything, you can always try to reach out or through the community education and leave questions there. Otherwise, I hope you all have a wonderful evening, and we look forward to seeing some of you back, hopefully in September, for our talk on recurrent urinary tract infections.
Thank you.
Thank you. Good night.